Good afternoon. This is Dr. Claudia Perez. I'm a breast surgeon at Rush University Medical Center. And thank you so much for joining us for a very special webinar looking at breast cancer treatment in the era of COVID-19. We have put together an excellent panel of our expert breast team who are part of a larger breast care team here at Rush, and I'll introduce them shortly. But thank you so much for joining us, and we will get things started. So a little bit about some housekeeping. We're going to make sure that your lines or your devices are muted as to avoid any background noise during the presentation and to optimize our audio. But please feel free to use the chat option to ask any questions that you would like. At the end of the presentation, we will be answering those questions. So just to get started, breast cancer, even in the era prior to COVID-19, we were very familiar with the number of 1 in 8 women. It's still the most common cancer diagnosis in women today, and it's still the second leading cause of cancer death. Traditionally, as a standard of care, most women with a new diagnosis of breast cancer have surgery as their first modality of treatment. And we have been forced to sort of re-look at this and reevaluate our timeline of care in the era of COVID-19. So what I think is very important and what will translate in our presentation today is that it's a matter of balance. It's a matter of weighing the risks of disease progression against the viral exposure to patients. And that's been our main priority as we've been moving forward, treating and diagnosing patients during the pandemic. We look at patient comorbidities and age to predict mortality from COVID-19. And we also look at the oncologic safety of perhaps delaying their care because it's the safer option in terms of their risk of exposure. I'm waiting for my slide to advance. Give me one moment. Okay, so the objectives of this presentation today is to take a comprehensive look at how we at Rush are navigating breast cancer diagnosis and treatment in the setting of this very unusual and new pandemic. We're going to look at the different modalities of care to include breast imaging, followed by breast surgery, the medical therapy for breast cancer, as well as the radiation therapy for breast cancer. And each of our expert panelists will talk about each one of these options. At the very end, we'll do a question and answer session. So please, again, feel free to use the chat option so we can answer your questions. So without further ado, I'd like to introduce our first panelist, Dr. Lisa Stempel. She is the acting director of our Rush Breast Imaging Department. Thank you, Dr. Stempel.
Thank you, Claudia. So I'm going to talk about how the breast imaging department at Rush is currently and has been operating during the COVID-19 pandemic. When the initial shelter-in-place order was issued by Governor Pritzker, there was great concern about having enough personal protective equipment, and most elective surgeries were canceled, most medical appointments were canceled or moved to virtual appointments. And at Rush, we canceled a lot of our appointments. We followed recommendations from the American College of Radiology, and we canceled all routine cases, including all screening mammograms, ultrasounds, and screening MRIs. We did stay open to accommodate limited patients who needed to be seen and could not delay their imaging. We did perform most procedures that had been recommended unless they were very low suspicion lesions or the patient didn't want to come to the hospital at this time. And all patients who had any kind of new symptoms, such as a lump in the breast or nipple changes, were seen in our department. We also continued to see patients who had incomplete screening mammograms and screening breast ultrasounds, and all patients who had a current diagnosis of cancer who required additional imaging or biopsies and MRIs. We also took care of our MRI patients who required additional imaging and biopsies. During this time, we had a limited schedule, and we operate in a safe manner, utilizing social distancing in the center. Patients and staff were screened upon entry and given masks. We've kept a zero visitor policy, and we made sure that all rooms were sanitized according to pre-existing recommendations. So now we have a new shelter-in-place order beginning May 1st. It's a little less restrictive. We will now continue to see patients who have deferred their biopsies or imaging from before due to the initial shelter-in-place. We're going to add in patients who have been recommended for short-term follow-up imaging if they would like to come in. And then we're going to begin to perform routine screening on our cancer survivors and our higher risk patients. We won't be offering routine screening for our average risk patients at this time. This will be based on further information from the state and the capacity of appointments. We're going to offer a safe environment. We are having a very thoughtful return to caring for our patients. Every patient will be screened when they're scheduled and then immediately prior to entering our facility for direct exposure and any symptoms. Our appointments are significantly reduced and spread out to allow appropriate social distancing in all of our centers. We're going to use extended hours and weekend hours to try to accommodate our patients. We're installing an e-check-in process, which will decrease time for patients in our waiting area. We'll continue to have a no visitor policy unless that visitor is required to get the patient to the center. We'll be limiting the number of staff in any area to allow for social distancing, and we're going to ensure that all staff and patients wear masks for the entire visit. We will continue to adapt our policies with further guidance from the state of Illinois as we get it. Thank you, Claudia.
Thank you, Dr. Stempel. We'll move now to Dr. Andrea Madrigrano, my colleague and also the co-director of the Breast Cancer Service Line. She's going to be talking to us about breast surgery and how we've been managing this during the COVID-19 pandemic.
Thank you, Claudia. I just first want to disclose that I have no potential conflicts of interest. In mid-March, the Department of Surgery was given a mandate saying that from the governor, saying that all elective surgeries needed to be canceled. It was very hard for women to hear that cancer at the time was going to be considered elective. However, we had to base these recommendations based on a consensus statement from members of the American Society of Breast Surgeons, the National Accreditation Programs for Breast Centers, the National Comprehensive Care Network, and the Commission on Cancer and the American College of Radiology. Breast surgery across the country was canceled. People called Rush, and when we said we couldn't accommodate them, we had heard that a lot of people were trying to find another place either in our state and in another state, but this was a universal national guideline that we all followed. We were then left to think, how can we treat cancer patients and keep our patients safe during this COVID pandemic? We also had to reconcile the fact that hospital resources and staff were more limited. Claudia, we were all asked to cover other areas of the hospital to try to help the COVID patients. Our nursing staff was pulled to also cover other services. And we needed to establish a triage method to kind of say what patient is in immediate danger and which patients can safely wait until the pandemic is in order. So these national guidelines outline 3 priorities. Priority A means a patient had an immediate life-threatening condition, like a breast abscess or a hemorrhage, that if we didn't treat them right there, it could lead to serious medical issues. Priority B, and this is where most women fell, it's a newly diagnosed early stage breast cancer was considered a condition that did not require immediate treatment, but couldn't wait for the 1 to 2 to 3 to 6 months. We don't know how long the pandemic's going to take. So we needed to start something, but maybe their traditional order of treatment would be shifted. And priority C is conditions that could be safely deferred until the pandemic is over, like a benign fibroadenoma or a benign lesion that needed to be excised, as well as prophylactic surgery. Also, the way we saw patients, I'm a surgeon, I like to see and examine my patients to know what I need to do. But we were told that we needed to take on this new form of medicine where we were seeing patients over a video visit or over a telephone call. And we were told that the majority of our encounters should be conducted remotely via telemedicine. We could still see our patients over the phone, we can still look at the breast itself, but we lost that tactile ability to examine. But it was more for our patient safety, keeping them away from the medical center, allowing them to shelter in place, and really practicing social distancing for the patients that truly needed to be in the medical center. So we still did continue to see patients. I had a series of breast abscesses that happened during this pandemic that needed to be addressed in person. We had some post-operative patients who needed drain care to take place. Priority B was a new diagnosis of cancer, but our new cancer patients were seen by a team of doctors, by a surgeon, a medical oncologist, and a radiation oncologist. And typically all three of us like to go in the room and interview the patient and examine them. But the national guidelines and our group decided that only one of us would actually examine the patient in case there was something that was different from what the records could tell us. And priority C, all our benign patients and the patients who had had a cancer in the past, we delayed most of them with their breast imaging until the pandemic is over. So the recommendation said that newly diagnosed patients should be seen in a multidisciplinary clinic. What I want to stress is that no woman with a new diagnosis of breast cancer during the pandemic was delayed treatment. We offered therapy, but maybe it wasn't what they expected to have their surgery first. Most patients are diagnosed with an early stage breast cancer that's receptive to female hormones. So many of these patients were placed on their medication like tamoxifen or anastrozole before surgery until the operating room was ready and a safe place for people to have their surgery. Really, the only operations we were doing were those women who were in a very close window after they finished chemotherapy for their advanced breast cancer. Thankfully now the operating rooms are back open at Rush for surgery. They're open for cancer care, and we've put a lot of things in place to make sure that the patients coming to the medical site for their surgery are being safe. One is that every surgical patient will get point of care COVID testing and provided with a mask. Rush, I was on a surgical meeting today. We have secured enough personal protective equipment or PPE to keep patients and providers safe. We're doing our best to keep the COVID patients, the cancer patients are operated in operating rooms that did not see COVID patients and are in areas of the hospital remote from where the COVID patients are being kept. An overnight stay is needed. It will be in a non-COVID ward. And for safety reasons, no visitors will be allowed. What we really want to stress is that it is although it's a very strong hospital for COVID care, we are still doing our best to keep our patients very safe, and we need to cure their cancer. So Rush is taking the steps necessary to keep the environment very safe. But with that said, we still are in a global pandemic. It's the best right now to keep your operations simple. Many women have a choice between a lumpectomy and a mastectomy. We're really strongly encouraging our patients, if they can have a lumpectomy, to have the simpler operation. It's a shorter operation. It's done with less anesthesia, and there'll be less back and forth between the medical center. We're really discouraging at this time doing prophylactic procedures, as many of them can wait until the pandemic's over. But we do want to stress that if a woman does need to have a mastectomy, we are still offering breast reconstruction.
Thank you, Dr. Madragrano, for that comprehensive look at surgery during this pandemic. We're going to move now to Dr. Ruta Rao, who is the medical director of Rush University Cancer Center. And Dr. Rao will talk to us about the medical treatment options and our mode of care from the medical standpoint.
Can you hear me?
Okay. Yes.
Great. So, to follow along with the themes of what Dr. Semple and Dr. Madragano said, our goal during this time has been to see and take great care of our cancer patients, but, weighing the risks of COVID. And so some of the changes we made in medical oncology were, as Dr. Madrigano said, we tried to do video visits as much as possible for our new patients as well as our follow-up patients. But that being said, we were still seeing patients with new diagnoses and chemotherapy in person, because some of these patients do need to be examined before we can make the decisions about whether to give them chemotherapy or not. As well, we have a multidisciplinary tumor board, which we were holding on a weekly basis, and we have continued that on a weekly basis in a virtual format. And this allows us to discuss between the radiologist, the pathologist, the medical oncologist, the breast surgeon, and the radiation oncologist, what is our optimal plan for these new patients? And in fact, these discussions have become even more robust in this virtual format. So again, in medical oncology, we also prioritize the patients based on national guidelines. And priority A were the patients who had immediately life-threatening conditions. And for medical oncology, that means things such as febrile neutropenia, hypercalcemia, intolerable pain, symptomatic pleural effusions, or brain metastasis, to name a few examples. And for these patients, we initiate necessary management for these conditions without even pause. So if they had to be admitted to the hospital, if they had to start treatment, or if they had to have drainage of their effusions, that was done immediately. The next category, which was priority B, were those patients who did not have immediately life-threatening conditions, but we knew that treatment or services for these patients could not be delayed indefinitely until the end of the pandemic. And from a medical oncology standpoint, the patients that fell into these categories were those who had a new breast cancer that was considered an inflammatory breast cancer, or if they had triple negative or HER2 positive breast cancer that was greater than 2 centimeters in size, or lymph node positive. And these were the patients that we started on chemotherapy in the same fashion that we would have prior to COVID. For our patients with metastatic breast cancer, for whom therapy was deemed to improve outcomes, again, we either started or continued their therapies, and these patients can be on chemotherapy, endocrine therapy, or other targeted therapies. And so for these patients, we started or continued their therapy as we would have pre-COVID. And for our patients who had their breast cancer treatments and were on oral adjuvant anti-estrogen or endocrine therapy to reduce the chances that their breast cancer could come back, we advise these patients to continue these therapies. And I'll tell you, I got lots of questions from my patients about whether these were immunosuppressive. They are not considered immunosuppressive. So we wanted patients to continue these therapies. They're generally medical therapies that they take for 5 years or 10 years. And so we did not want them to pause on these during the COVID pandemic. Some patients who had earlier stage breast cancers that were stage 1 or 2 and estrogen receptor positive or HER2 negative, and because of conditions that allowed them to not have surgery immediately, we saw these patients earlier than we would have, and we started them on anti-estrogen therapies as they were waiting for their surgeries to be scheduled. For us, most of these patients were seen towards the end of March and the beginning of April, and these are the patients that are now being contacted to get their surgery scheduled again as we see operating rooms open back up. We also consider doing gene expression assays on the core biopsies for these patients. These were tests that we normally would have done after the patient had surgery. And so these were some of the decisions that we had to make that altered the order in which we would do things because of the COVID pandemic. Similarly, for patients who had estrogen receptor positive ductal carcinoma in situ, or what we call stage 0 breast cancer, again, if their surgeries were deferred, we talked to these women about starting endocrine therapy while they were waiting to have surgery. And the group of patients in whom we considered priority C were those that were considered that their treatment or services could be delayed until the pandemic was over. These included patients receiving bone supportive therapies such as denosumab or zoledronic acid, unless it was being given for hypercalcemia. Some of these patients had their therapies delayed, but we did not feel that these were life-threatening conditions that needed this therapy. Similarly, our patients who had very stable metastatic breast cancer, we were advised to delay the interval for routine follow-up restaging studies. So if someone was going to have a restaging scan in the middle of March or April, sometimes these were delayed till May or June. So we just want to emphasize that during this COVID pandemic, we have been keeping the clinic as safe a place as we have as possible. We are similar to mammography and surgery. We are pre-screening all of the patients coming to the clinic. So we have a nurse who calls them the day before they're coming to clinic to screen them for symptoms. If they screen positive, then they're taken to our urgent care. And this is an urgent care run by our own Rush University Cancer Center nurse practitioners. And these patients are taken straight to the urgent care on the ground floor to be tested. We have a point of care test that gives us immediate results on their COVID status. We also started a zero visitor policy. And at first, our patients were a little surprised by this because they were used to having their companions with them during treatment. But afterwards, many of them thanked us for actually doing this, saying that they felt better not having so many other people in the cancer center. Our staff has taken all the precautions, wearing masks and gloves, as are our patients. And we have also opened our infusion and urgent care on Saturdays and Sundays to spread out the number of patients coming to clinic and to offer services on Saturdays and Sundays so that our patients who aren't feeling so well can come to our urgent care instead of going to the emergency room.
Thank you very much, Dr. Rao. We will move on now to Dr. Brett Cox. We are very proud to have him part of our breast cancer team. He's the chairperson of radiation oncology, and he will be talking about the radiation therapy during this COVID-19 pandemic.
Thank you, Dr. Perez. It's a pleasure to be able to spend some time with you. I thank all of the participants. I am proud that you are empowering yourselves with information and your care. Just to start with, as a radiation oncologist, I spend much of my time explaining what radiation is to both patients and physicians. So those of you just starting your cancer journey, or those of you in the middle of it, I'm hoping this is useful. For those of you who are aware, let me just give a quick introduction. Radiation oncology, or radiation therapy, is an important component of breast cancer treatment. It's critical. We will do radiation after lumpectomy or mastectomy in certain instances. And basically, we can do it with external radiation or internal radiation, as you can see the pictures above. Basically, radiation is a very efficient way to kill cancer cells with high energy radiation beams. It's very safe in this day and age in the sense we have advanced computer technology and we have imaging to make sure that we are protecting normal tissues. And so we just hit the areas at risk and we minimize the chances of having a side effect or other problems. There's a lot of confusion about radiation therapy, but it's more common than you would think. It's common, it's safe, and effective. 2/3 of patients receive radiation if you have a cancer. And we try to treat people, we try to cure people 2/3 of the time. And so if 40% of the US population will be diagnosed with cancer during their lifetime, that means that 1 in 4 Americans should receive radiation therapy in their lifetime. Next slide.
Give me one moment, Dr. Cox. I'm trying for you.
Thank you, Dr. Perez. No rush.
Mm-hmm. There we go.
So at Rush Radiation Oncology, during the pandemic, we remained fully operational, and we've treated all medically necessary cancer patients. We haven't delayed anyone's care if we thought it would lead to a negative cancer outcome. And that's because we treat people with a variety of different cancers, but this has included breast cancers. As everyone before me has mentioned, all the other physicians, we take a personalized treatment strategy for each patient. It's a tricky situation right now, even for the physicians. We don't know exactly what to do. We use our best judgment, but nobody has ever been in this situation before. In radiation oncology, we use that tiered risk approach. If you have to have treatment right now, we will absolutely do it, and we'll do it well. If there is no harm to wait with your cancer, particularly a month ago, we'll wait. But basically, it's all about the balance of the risks and benefits of the cancer, the treatment, and the COVID situation. So there's not a formula. It depends on the woman coming in, the treatment that they need, what their priorities are, and what their medical situation is. In our department, just like the rest of Rush, we follow all national recommendations for quality and safety. We prefer to do in-person visits like every other physician. This is still a field where we like to sit with people, do physical examinations, get a sense of what is important to them with body language and other things like that that are important in this human field that we're in. But we also do video visits if appropriate, particularly for follow-up visits or other things like that. We maintain a full environment of safety for both our patients and our staff. And just like you can tell from the rest of the group, we work as a team. Nobody acts by themselves. We discuss every case amongst each other. We have full multidisciplinary participation. So just to summarize, and I think this is not anything that hasn't been said already, Rush is a national leader in patient safety, and we take it very seriously. We protect our patients. We protect our staff. We screen everybody who comes into the building. We have the most advanced and aggressive testing procedures. We're recognized in both the region and the nation for what we do. We have comprehensive cleaning and sanitation procedures. The zero visitor policy is important for the protection of our patients. I know it's disconcerting, as others have mentioned, used to having a support person there, but it's for everybody's safety. We use appropriate social distancing, and unlike other issues you may have heard in other countries or other states in the US, we have full protective equipment available. Gowns, masks, gloves are fully available. So from the radiation oncology perspective business, we've been open, we are open, we've been safe, and we're treating people if necessary. At the same time, we're modulating our recommendations to make sure that the patient's health is maximized. I appreciate the ability to be able to speak with everyone.
Thank you so much, Dr. Cox. So don't be shy. Please enter your questions in the chat section of this webinar. I can start with one question, though, to the panel. This one will probably be perhaps for Dr. Rao. We have a question from one of our audience members. What are your opinions on long-term immunodeficiency for survivors who have had chemotherapy in the last 12 months or Herceptin treatment? It states that she had stage 1 right breast cancer, no genetics. She had a lumpectomy, 12 weeks of Taxol, 20 radiation treatments with boost completed in January of 2020. She will finish her Herceptin in August and on tamoxifen, but she has kids and she wonders if she can let them go back to school in the fall, or does she need to isolate for them and for how long? Dr. Rao, I think you're muted, so let's try to unmute you. There you go.
Can you hear me now?
Yes, thank you.
Great. So these are great questions, and I think, you know, questions that a lot of cancer patients are asking us and probably around the country. I think the highest risk of immunosuppression is for the patients who are currently on chemotherapy. So in this case of this particular patient, since she has completed her chemotherapy, she's in a slightly less immunosuppressive situation. That being said, she's still on antibody therapy with Herceptin, which sounds like it'll continue for a few months. And as is being advised for everybody, even non-cancer patients and patients not on immunotherapy, I would advise her to take all the precautions to stay home, stay safe, and shelter in place as much as possible. I think the question about the children and going back to school is an excellent one, and all of us who our parents have the same question about whether our kids will actually go back to school and when that will be. So I would say in terms of answering that question, I think we'll just have to wait and see what happens over the next few months with the numbers. It was really encouraging to see some nice news out of New Zealand today, where they even had a day where there was only one case. So it's nice to see that that actually is a possibility in the future. And I hope that with all these measures that the governor has put into place for shelter in place, we can one day get there.
Thanks, Dr. Rao. Here's another question, likely for Dr. Cox. If you receive radiation treatment, does it make you immunosuppressed or more at risk for COVID?
That's a fabulous question. With standard breast radiation, either after lumpectomy or after mastectomy, generally you are not immunocompromised from the radiation in the sense that your blood counts aren't down, and we don't think that you're more prone to having an infection or other problems from the radiation itself. Obviously, by the time you get to us, there's a history of chemotherapy and surgery, but generally radiation in and of itself doesn't increase your chances of being immunocompromised. In terms of does it make you more risk for COVID, we do not think so for breast cancer patients. In the modern era, we're able to treat the breast or the chest wall very safely with little or no doses to the lung that are carefully tracked and known to safe levels. There have been some reports in the medical literature, if you're treating patients with lung cancer, where you have large amounts of the lung in the radiation field, it may make it more likely that you either have COVID or do more poorly with COVID, but that's certainly not proven from breast cancer because there's very little actual lung tissue in the radiation field.
Okay, another question from the audience. If someone tests positive for COVID on prescribing, do they need to delay their treatment? So essentially, if a patient is deemed COVID positive at the time of their treatment diagnosis, do they need to be delayed?
So again, I think this is a question that really is very pertinent right now, and it's a matter of weighing the risks and benefits. When a patient tests positive for COVID, it's generally because they have some symptoms that led to the testing. And so in those situations, we want the symptoms to resolve. We're talking about putting into place policies to have 2 negative tests before we would restart any immunosuppressive therapy as well from a medical oncology standpoint.
Okay.
And I think from a surgical standpoint as well, if someone's COVID positive, there's a high chance of aerosolizing the virus in the operating room and potentially spreading the disease to the people who are helping with the operating room. So unless it's life-saving surgery, and some people with active COVID have needed life-saving operations, those would still happen. For breast cancer surgery, we would, Dr. Rao said, want 2 negative tests before taking them back to the operating room, because there are also some ramifications for having anesthesia and wanting to be able to have the people breathe freely.
From a radiation perspective, if you need radiation right now and are COVID positive and the risk of the cancer is more than the COVID virus, we'll treat you if you're COVID positive. We will not delay your care. Obviously, that's a rare situation. We haven't encountered it yet. But ultimately, we're not going to delay life-saving care or cancer important care for COVID positivity because we have the ability to do it. So if it's more important to treat the cancer, we can treat COVID positive patients safely and effectively if it's necessary.
Okay, next question as I scroll through. I had BCIS stage 0 and my 1-year anniversary. I'm having a hard time seeing this. Give me one moment. My 1-year anniversary from the biopsy is April 30. My 1-year diagnostic mammogram was May 4 and canceled. I have a 5/22 appointment. I'm only seeing part of this question. Give me one second. Give me 1 second. I'm only seeing a partial question.
I can read it to you, Claudia. I'm able to see
There we
it.
go.
Oh, okay.
I see it now. I have a 5:22 appointment for Zometa infusion and 5:27 follow-up appointments with Dr. Madrigano, hello, and Terry. Will I be able to be seen in May?
Is this for breast imaging?
I think it's for both. I think first we could start with answering the question about the mammogram that was canceled on May 4th.
So this is a yearly routine mammogram. If it was canceled on May 4th, that's because we've had to cancel many patients to put in new appointment templates. We can't let people have the same appointments we have because of social distancing constraints in all of our centers. But if it was canceled on May 4th, it certainly can be rescheduled. And we have a list of all patients that were canceled that we will be contacting to reschedule, but you can also call our scheduling line and get rescheduled. We are doing routine exams on our cancer survivors beginning May 4th.
And regarding the additional appointments for infusion and follow-up exam appointments with surgery and medical oncology?
So I would advise, from a medical oncology standpoint, I would advise this patient who's asking to reach out directly to Terry Doherty about the appointment and the infusion.
From a surgical standpoint, we are really seeing patients if they need to be seen. As imaging starts to open up again and as we are screening again, we are allowing for patients to be seen if deemed necessary. And it's very case by case, and contacting that direct nurse or that direct physician can help guide you. So next question, I will be starting chemotherapy tomorrow. What other precautions should be taken to protect for COVID?
So in general, the clinic is taking all the extra precautions we talked about, using the social distancing, doing the pre-screening of patients beforehand. We are checking everybody's temperatures as they walk in. Anybody with a fever will be checked for COVID with the point of care test. In terms of additional precautions, I would, advise you to keep your distance from everybody at home, follow the shelter in place rules, don't go out, try, to avoid contact with more people than necessary. And most importantly, wash your hands and don't touch your face.
Okay, here's a good question. How does increased level of alcohol consumption affect breast cancer patients and survivors?
That's a great question. We have studies showing that alcohol consumption, which was in that study defined as 2 drinks a night on a consistent basis, seems to have a negative effect on cancer survivorship. So in general, if you're drinking at that level, then I would tell you, to talk to your doctor. Short of that, having an occasional glass of wine a couple times a week, we do not think negatively impacts cancer survivorship.
Okay, here's a nice shout out for Drs. Madrigano and Dr. Rao. It's been 4 years since her diagnosis of breast cancer and almost 4 years since her mastectomy. And she says a huge thank you and shout out. She's a survivor because of you, with very deep appreciation. And this is Marianne Weria.
Thank you very much for that.
Thank you.
Okay. Here's a question. While you have been changing the order of treatment, do you think that will change the overall prognosis for a patient?
So our goal was to provide patients treatment that would not compromise their chances of cure. So we did not make any decisions that we felt would negatively impact their chances of cure.
In the same respect, nationally, yes, we did change the order, and we are following some data. A lot of women who have more advanced hormone receptor positive cancers are actually placed on endocrine therapy before surgery to help surgery become easier or to make someone into a lumpectomy candidate. With that said, we are following these women. We are participating in a COVID national registry to answer that question. Is it going to matter? We think it's not, and we are doing the best to weigh the cancer risk and cancer treatment with exposure. So it could be that we change the way we practice medicine based on kind of all the different things we've learned during COVID. My hope is for some women, telemedicine does provide some care for women who live far away or who can't get off work, who just have some clinical questions to answer. It's a great way for us to be able to provide second opinions for people who live far away. So I think we're learning a lot about COVID, and it will likely change medicine in a good way in the future.
And I would like to add that we are changing our practices sometimes on a day-to-day, sometimes on a week-to-week basis. And in the end, the patients that were delayed, so to speak, for medical therapy prior to surgery when we weren't doing surgery didn't have an extensive delay. And that was good. We were happy to see that we were open to do surgery again for cancer and hopefully soon for other surgeries as well. Okay, here's a good question. There have been many controversial theories of how long COVID lasts on surfaces. Are additional cleaning techniques being added? Any thoughts on that from the panel?
Yeah, I'll take that. There is a great deal of time and effort spent making sure that we keep our hospital clean and safe. So there have been additional protocols in terms of wiping down floors, elevator panels, rooms, clinic rooms, treatment machines, and these are taken very seriously. And so we do have extra protocols in place in the institution to make sure that it's clean and safe. That is both whether or not we think that there's been an exposure of the area to COVID or not. So we have increased our hygienic protocols within the institution.
Okay, if we have a support person to drive us to Rush, is there any place at Rush for the person to wait while we are in our appointment?
So I know it's very difficult right now because we are asking in all the different specialties for a zero visitor policy. I think the safest place for the driver or companion to wait is probably in their own car, just to reduce their exposure to anybody else. Along those lines, in the cancer center on the 10th floor, if patients need some extra assistance getting from where they're being dropped off by their driver up to the 10th floor, we have started a service with our medical assistants where if you call, they can come down and get you. If you need a wheelchair or anything like that, they will bring that for you and take you upstairs. And if, you know, as you're coming close to the end of the treatment, the nurses can let you know and you can call your driver or support person, and our staff will again take you back down to meet your driver. So we're doing everything we can to make this work for our patients in the safest way possible.
And breast imaging is providing that same service that if you call, we will send someone down to bring you up to breast imaging.
In terms of radiation oncology, we have dedicated parking right outside the door, and we have staff who can help you ingress and egress from the department. So it's very easy to reach us given our physical location.
Okay, next question. With a low oncotype score, my treatment was a lumpectomy and radiation, January and March respectively. Am I now considered cancer-free?
Yes, in a situation like that, we would consider you cancer-free from the time you had the surgery. Every treatment given to you after the surgery was to try to reduce the chances that the cancer would come back in the future.
And this one's for you, Dr. Cox. I had a mastectomy on March 3rd. Can I wait to have radiation until the pandemic is over? And can you speak a little bit to how safe it is to wait, given the fact that some women have had delays?
Right, and so that really depends on the situation of what they found when they did the mastectomy, as far as the extent of the tumor, its characteristics, and if it had spread to the lymph nodes. So what I would recommend is, I can't say just given that if it's safe or not, but I would talk to your surgeon and see what him or her has to say. And then what I'd recommend is that if you haven't already, make an appointment with a radiation oncologist, and we can talk about the specifics of the tumor. Some women in your situation are definitely able to safely wait for 4 to 8 weeks. Other women, we'd recommend getting started sooner than later. And so I'd recommend actually talking to your doctors, both your surgeon and a radiation doctor, to make that determination.
Okay, I really like this question. It's a really good one. Is there a place for the driver waiting in the car to go to the bathroom?
There are some bathrooms on the first floor of the professional building in the hospital, and I'm sure if you came inside and said that's what you needed to use, I'm sure they'd be happy to let you use the bathroom. But just wash your hands really well after.
Yeah, that's a valid question. We have everyone entering the hospital wear a mask, and so you will follow those protocols. And again, all of the recommended hygiene that we use for COVID-19. Okay. Your stress levels must be high. Any favorite personal activities that you have instilled in your own lives that you can share that you think would benefit others with stress and anxiety now? Thank you for doing this WebEx. Well, it's our pleasure doing the WebEx. We're so happy to have such a large, robust group listening and hearing about what we're doing here at Rush. I can start. I think that, this whole process has been kind of isolating. So one of the best things to do is try to stay connected while you're social distancing, whether that's calling friends, calling family, doing the WebEx or Zooms virtually, but really trying to stay connected, and then taking some time during the day to just clear your mind, and whether that's yoga or meditation or just being alone and in a quiet place. I think all of that can be beneficial. And I think it's really important that we do take time to do that in this uncertain time period. Anyone else want to share?
I personally
have two strategies. I've been doing Zoom happy hours with friends and colleagues. And I also bought a new Bernese Mountain Dog puppy, which is keeping us busy. So it's been a great strategy to kind of take off the stress to have a little puppy.
That's wonderful. My kids would love if I got a puppy, but I just can't right now. So I agree with Claudia. I think it's really important to keep connections with friends, with work colleagues. I mean, I really miss seeing a lot of my patients in person. It's lovely to see their faces on the WebEx, but I look forward to the day where we can go back to seeing each other in person. And so it's really important to keep those connections. And the other thing that I've started doing is taking just long walks outside by myself, either listening to a book on tape, something completely not related to COVID.
Well, I have 2 e-learners at home. So of course, e-learning has really helped my stress. But actually, 2 people learning fractions at home. So we have baked a lot of cookies and banana bread and eaten a lot of cookie dough, but at the same time, pretended to practice our fractions.
Okay, excellent.
I agree.
So here's another question.
I agree with all of you.
Sorry, go ahead.
I was going to say the Zoom happy hours are very, very helpful, and we're eating a lot of banana bread at my house as well.
Okay, great. This patient or audience member has had several symptoms of COVID-19 since late January. She came in to see her PCP, did not have pneumonia or influenza A or B, had a CAT scan that showed bronchitis. would she be eligible for testing to see if she has the antibodies? It's been 3 years since their diagnosis, and she says, Rush rocks. Thank you.
I would recommend calling the Rush COVID hotline, which I don't have right in front of me. But if you're a patient who's been treated by us, they can guide you as to your symptoms right now and recommend the right testing to do. I know that many primary care offices, have been overwhelmed or under stress right now, but our testing protocols are impeccable. I'd recommend just calling that hotline. They have your medical record available. They can assess your symptoms and recommend any testing that might be necessary.
Okay. Do we know when reconstruction, plastic surgeries will become available again if they aren't already?
So women having mastectomies now are offered breast reconstruction. So we are doing the first stage. I think when we get caught up with the cancer cases, the plastic surgeons will open up their practices to do the second stages and the more the tweaking of the previously reconstructed breasts.
And to backtrack a little bit, that COVID hotline number is 888-352-7874. 888-352-7874. We'll be sure to put it in the chat before this is over. So this patient has completed a series of chemo and lumpectomy and radiation completed in the first week of March. They have battled a respiratory virus and now a rash, hoping to get back to work as it resolves in a few weeks. She did test negative for COVID. How do you feel about those of us who are both recent cancer survivors and in essential businesses going back to work? She works in construction and real estate.
This is the million-dollar question. I think that we're trying to balance on a public health level the safety of the patients versus, the economy and people's lives and jobs and welfare. And so I don't think anyone can give you a solid answer as to this. What we want is that when people go back into the workforce, if they're doing essential work, that they're safe, they're practicing proper safety and social distancing procedures. Given the specific symptoms, it's important that the symptoms go away. It's good that you've had a negative test. But I think that you're going to get mixed feelings, obviously, when you look at the news about how people feel about how quickly to escalate away from maximum social distancing into, people getting back to business. I don't know if other panelists have an opinion, but that's it's a very good and it's a very tricky question that I don't think anyone in the United States has the right answer to.
I agree, Dr. Cox. And I think the one thing we've learned from this is that when people are feeling sick, they should stay home, whether it's work, whether it's school, all of those things. We have to take those, people being sick much more seriously than we ever did in the past.
I think this question is asking if they should get COVID testing. It states that I don't have any symptoms of COVID now, but had 2 weeks fever and severe cough and body ache. I think typically in that scenario, you'll want to contact your primary care doctor or also the COVID hotline number to get further direction. We're really testing people on a case-by-case depending on their symptoms, but the hotline really does great guidance. Once you call the number, a nurse will triage either to a video visit or to get testing. So I think we've gone through the questions online, but I have another question that's coming offline. How do I know if I'm immunocompromised? I don't have active cancer right now. However, I did have cancer in the past. Do you consider me immunocompromised?
I'm sorry, what was the treatment that the patient had? And are they currently on it?
No active treatment. Treatment was for breast cancer in the past, and so they're a survivor.
So in general,
and no current therapy.
We don't consider survivors to be immunocompromised. And again, just to emphasize, our survivors who are on anti-estrogen therapies, we do not consider them to be specifically immunocompromised either. But again, everybody should be following the hand hygiene and shelter in place right now.
Here's another offline question regarding imaging, Dr. Stempel. My mammogram was canceled. It was a screening mammogram. Should I be concerned that it's been delayed now almost 3 months?
No, we don't feel that a delay of 3 months should be of concern. If you are a cancer survivor, we are now opening up annual screening to cancer survivors, so you can call to make your appointment to come in. Routine screening for patients with no symptoms, no history of cancer. We're hoping to open that up when the shelter in place is lifted, at the end of May. But the cancer survivors certainly are able to come now. I do not believe there's any literature anywhere that would say a 3-month delay should cause any problems for you.
Okay. Here's another question. Are you changing any treatment recommendations for imaging or surgery based on age? I think that's how the question reads. Are you changing any treatment recommendations, imaging, surgery based on age?
I would say if someone has breast cancer and it's an early stage breast cancer, I think we would we're recommending the same surgeries now that we did before COVID.
And the imaging recommendations have not changed either.
Same for radiation.
Okay.
And I would say same for medical oncology.
Thanks, Ruda. How can we best support you? Thank you for all you do, especially now. Well, I think we would all agree that the best way to support us who are working in the healthcare field is to really follow the rules regarding social distancing, staying at home, keeping yourself from being exposed as well as vice versa. And by you doing that, it really helps us to slow the spread of this virus and flatten the curve, which is what we all really want to do. Other thoughts from the team?
I completely agree.
And today we're giving the message that Rush is here to help you with COVID, of course, but really our foundation is great and multidisciplinary cancer care. We want you to go back to your community and let people know that Rush has taken all these steps to make sure that cancer care can happen in a safe way, and that the services that we can provide you now are on par with the services that we provided you before the COVID pandemic.
Here's another question about the logistics of dropping a patient off to the hospital. Does the policy, driver drop-off patient hospital helper, that comes for the patient work for outpatient lumpectomy procedures? So I can start with this. Andrea, you can add on. Currently, we are having our patients dropped off to get registered for their outpatient procedure. The driver or the person who is expected to drive that patient home is allowed to wait in the waiting room with a mask, keeping our safe 6 feet of social distance. And then the surgeon is able to speak to that person when the procedure is completed, and then they can take their loved one, their family member safely home. Now, that being said, if a family member does not want to come into the hospital for risk of exposure, then we can always call that person and notify them when it's time to pick the patient up.
But I want to stress too that no patient will go home just wheeled down in a wheelchair to their family member without instructions given both to the patient and to the family member, so that everybody knows what to expect for the recovery period and has all the correct instructions.
Okay, another question. I've completed surgery, RT. I have not had my follow-up for surgery yet. It is rescheduled into June. When do I need to do follow-up imaging? I can start. It really depends. We typically do imaging after surgery at a 6-month interval. So it would really depend on the date of your surgery and when your annual mammogram is due. We typically space those out 6 months apart. If you've been delayed because of this, we're not worried about delaying that imaging, and our teams will be reaching out to you to get those rescheduled. We are really not leaving you hanging. We are keeping track of all the patients who are delayed or rescheduled and making sure we follow up to give them appropriate imaging timing.
Yes, and breast imaging is open for appointments.
Thanks, Lisa. Okay, here's another question. I have an appointment with Dr. Dudney May 19. I am a 3-year survivor. It is time for a CAT scan also. Should I consider rescheduling for later in June or July?
So I think the best advice we can give you in that situation is to contact Dr. Dudney specifically to see what her feelings are, if she wants to see you and whether she feels that your scan can be delayed or should be done now.
Dr. Rao, maybe you can field this again. This is a common question. A patient has completed chemo a year ago, March, and completed radiation this past July. Am I considered to be at high risk as far as being immunocompromised?
Sure. So again, as long as the patients are not on active chemotherapy or having just finished active chemotherapy, we don't believe that you're specifically immunocompromised. So it's good that you finished it a year ago, but I would still caution you to take all the social distancing and hygiene, hand hygiene and wearing a mask, and all of those recommendations seriously.
Okay, so this is a survivor who's very anxious about getting her port flushed. When should she have that done? Is it safe to come in and get that done if that's all she needs done?
Sure. So this is another excellent survivor question. Pre-COVID, we were recommending that the ports were flushed at least every 3 months. We've actually now, given the current situation, extended that to every 6 months. But if it is time and it has been 6 months for your port, we would advise you to come in and get it flushed. We do have hours open on Saturday and Sunday when there are less people in the clinic, so that might be an option to come in and get it done at that time. So please contact your nurse or physician or your healthcare team and find out exactly when the best time for you to come would be to get that port flush.
Thank you. I think we get that question a lot. Patients who have regular scheduled maintenance types of exams or procedures and what to do about that. So thank you. Another question offline. I have breast cancer. I've already had my surgery, but I really wanted to have a prophylactic mastectomy at the same time. Given COVID, it was recommended that I wait. When do you think it is a good time to do this?
So I think we have to see what COVID's doing. I wish I could tell my kids that they'll go back to school in the fall. I think once we know the trajectory of this disease, we better predict if we're on the upswing, are we plateauing, or if we're going down, we'll better be able to guide that question. But just know that prophylactic surgery or removing a healthy breast does not help you live longer. I know a lot of people want to have prophylactic mastectomies for peace of mind, but know from a cancer perspective that healthy breast will likely not do you harm. And we have excellent screening modalities that if, gosh forbid, something were to happen, we would find it very early when it could be treated, hopefully rather simply.
Yeah, I would agree with that. And I think the goal at this point is to keep things simple, keep things straightforward, decrease your risk of complications, and focus on the cancer therapy. And then eventually we will get to that prophylactic surgery that you desire. Okay. I'm seeing the chat questions sort of slow down. Are there any other comments from the panel?
Claudia, I saw a question on here that I just wanted to make sure that we addressed. Somebody asked about having an appointment at Rush Oak Park in June and wanted to know if that was still going to happen or they would go to the downtown hospital. So a lot of you who are our current patients probably know that with the pandemic, we did temporarily close our satellite clinics at Rush Oak Park and at Lisle. The good news is we are now in the process of talking about opening these again. And so we're really hoping to open them up by mid to late May. Right now, if you're scheduled for June, I would say just stay tuned. We're hoping to be open by then. We are working on everything that we can to have the clinics open again by then. And Lisa, I don't know if you want to comment about mammography at the satellite sites.
Yes, thank you, Ruta. We are opening all breast imaging sites, including Oak Brook, Rush Oak Park Hospital, and Rush South Loop starting May 4th for all kinds of exams. Our Lakeview screening will not be open at this time because it's only for routine screening, but as the shelter in place gets ordered, that will be open as well.
Great. And I know for our patients who need CT scans and other sorts of imaging that our downtown location as well as the satellites are open for other radiology tests as well.
Okay, we have another question. I am supposed to have my final reconstruction in June. I will have had my tissue expanders in for a year. Will I be able to get the surgery? How long is it safe to keep tissue expanders in?
Well, I think you should contact your plastic surgeon. We are trying to get caught back up for the cancer cases that we did get delayed. It's actually safe to keep tissue expanders in as long as they're intact. They're full of saline, so you would know if they weren't intact because the breast would deflate. Claudia, do you have any more thoughts about that?
I would completely agree. I think that have some reassurance that it is safe to have your tissue expander in for the year it's been in. You should follow through with your plastic surgeon, and they will guide you as to when you can get this next surgery.
And actually, our plastic surgeon, Dr. Shanak, just chimed in. She says it's very safe to still have it.
Thank you, Dr. Shanak, and thank you for joining us tonight. Here's a great question. Is breast MRI available anywhere besides the professional building? So anywhere else but the main campus?
So at this time, breast MRI is only available on the main campus. If it hadn't been for the COVID pandemic, we were scheduled to open breast MRI at Rush Oak Park and Rush Oak Brook this month. That has been delayed, but I'm hoping in the next couple of months we will be able to offer breast MRI at both Rush Oak Brook and at Rush Oak Park Hospital. Right now we only have it at the main campus.
Here's a great question offline for Dr. Kopp. Are you offering any different kind of radiation because of COVID-19? For example, a shorter course?
That's a great question. And the short answer is that we are changing our practice slightly. Most women with an intact breast who've had a lumpectomy, the normal range of standard of care is between, I would say, anywhere between 4 to 6 weeks of radiation therapy, even 3.5 weeks at the minimum. What we know is that all of these different lengths tend to work the same. And so in medical practice, people kind of held on to their own habits. But generally, we know that we can get most women completed, depending on the intricacies of the case, within either 16 to 20 treatments without any detriment to either treatment outcome or cosmetic effect. And so these are newer regimens that are proven in the evidence-based literature, but just historically, everything in medicine happens very slowly in the sense of you have physicians who are set in their ways. So we have moved to some shorter treatment regimens, but we were doing those anyway. We're just doing it more often. So again, I think it is the wave of the future to have shorter radiation courses, but we have not done anything that would either sacrifice the cosmetic outcome or treatment outcome of the patient. But our practice has changed slightly, which is a good thing for patients, to be honest with you.
Very good. Thank you for that answer. As the questions slow down, I would ask any closing remarks from the panel.
I would just like to say that Rush Breast Imaging is opening all sites beginning May 4th. We will be opening safely with social distancing in mind. Everyone will be wearing masks, and all cancer survivors who are due for their exams can call to schedule their appointments starting now. Thank you. Thank you for having me.
I know that this is a very uncertain time for everybody in general, and especially for our cancer patients and our cancer survivors. We just want you to know that we're here for you. Please reach out to us with any questions. We were happy to answer these questions tonight. If you have any other questions, don't hesitate at all at any time. We have our all of our teams ready to reach out and be your support as much as we can during this difficult time.
I also just want to thank my colleagues for us working together to be able to put on this webinar. I'd like to thank Lakshmi Venugopal, who set out all the invitations and coordinated these efforts. But mostly I want to thank everybody who participated. I think we've all gotten used to this new normal of webinars and WebExes and Zooming. So thank you for all the people who came out tonight to listen to us talk and for your questions. And just know that we're all here to provide you the best care that we can.
So with that, I would like to thank our panelists, Dr. Lisa Stempel, Dr. Andrea Madrigano, Dr. Ruta Rao, and Dr. Brett Cox. Thank you to our IT team for getting this set up. It wasn't an easy task, and we appreciate all your help staying late to get us set up. And, this is a sometimes very uncertain time. It's important for you to know that your healthcare team is here. Don't forget to lean on them. Don't forget to use them. Don't forget to reach out for their support. It's something that we are committed to getting you through your cancer experience, and we really want you to know that you're not alone. So thank you for joining us tonight. We just appreciate being part of our community, and we are here for you. So please stay safe. And thank you again to our expert panelists. Thank you to the entire breast cancer team, which is larger than this group that you saw here tonight. And please, everyone, be safe and well.
Thank you.
Thank you.